Okay, today vitreous fluid. As you know very well, aqueous is a dynamic fluid which gets secreted and it circulates and it gets drained. So there is 24/7 production, continuous production of aqueous fluid, while vitreous you can probably call it as static because there is no continuous production in the vitreous. This diagram will show you the extension of the vitreous, where it stretches from which place to which place. It starts from the posterior aspect of the lens and it occupies the space up to the optic disc. Okay, vitreous contains more than 98% of water and the refractive index of the vitreous is 1.33 and it has got a viscosity which is more than 2 to 4 times that of water. This is just a diagrammatic representation to represent where the vitreous is present. As you know very well, it occupies more than 4/5 of the volume of the eyeball. Coming to the embryology, there is a detailed embryology of vitreous, the details of which you are not supposed to know. And I would like to summarize the embryology of the vitreous into 3 possible lines, wherein you can remember that the summary of the embryology of vitreous is like this. Primary or the primitive vitreous is mesenchymal in origin and is a vascular structure having the hyaloid system of vessels. Secondary or the definitive, also known as vitreous proper, is secreted by neuroectoderm of the optic cup. Tertiary vitreous, which forms the ciliary zonules, is developed from the neuroectoderm in the ciliary region and is represented by the ciliary zonules. This is a summary of vitreous development. If you know these 3 lines, that is more than enough as far as the embryology of the vitreous is concerned. What is coming to the applied anatomy of vitreous? Vitreous humor is an inert and it's a transparent jelly-like structure that fills up the 4/5 of the cavity of the eyeball and the volume is 4 ml. It is a hydrophilic gel with optical functions and it forms one of the media through which the light rays pass through the various optical media in the eye before reaching the retina. Mechanically, vitreous also stabilizes the volume of the globe and it also acts like a pathway for nutrients to reach the lens and the retina. Coming to the structure of the vitreous, it is composed of network of randomly oriented collagen fibrils interspersed with numerous spheroidal macromolecules of hyaluronic acid. So it is basically collagen fibrils with hyaluronic acid with glycosaminoglycans. Whenever the vitreous liquefies, it is known as vitreous collapse. The conversion of gel into the into the solution is referred to as collapse of vitreous. Vitreous can be divided into 2 parts, cortex and the nucleus. Nucleus forms the main vitreous body, while cortex forms the peripheral abundant fibrils of the vitreous. Coming to the cortical vitreous, it lies adjacent to the retina posteriorly unto the lens, ciliary body and zonules anteriorly. Density of collagen fibrils is much greater in the peripheral part than in the central part. Condensation of these fibrils form false anatomic membranes which cannot be discerned even with the slit lamp biomicroscope, and they are anterior hyaloid membrane and posterior hyaloid membrane. you must know where these two membranes are present. Anterior hyaloid membrane is attached to the posterior part of the lens, while posterior hyaloid membrane is loosely attached to the internal limiting membrane of the retina. That is the innermost layer of the 10 layers of retina. Main vitreous body, that is the nucleus, it has a less dense fibrillar structure. It's a true biological gel. This is the site where the liquefaction of the vitreous gel starts first. Normally, liquefaction starts as a form of senility after the age of 65 years. And when it starts in the nucleus first. Centrally, you have an hyaloid canal, which is also referred to as Clockett's canal, which represents the remnant of the hyaloid artery of the fetus. You must remember various firm attachments of the vitreous. It is firmly attached near the vitreous base. Part of the vitreous about 4 millimeter across the ora serrata, where the attachment is the strongest. That particular part, this 4 mm, where it is attached firmly across the ora serrata, is referred to as vitreous base. Other firm attachments are again in the posterior aspect, around the margins of the optic disc and foveal region in the posterior aspect, and in the anterior aspect it is attached firmly to the crystalline lens, and this attachment is referred to as ligament of Weger. This is a diagrammatic representation of cortical and the nuclear parts of the vitreous. You can see the Clockett's canal. Anteriorly, it is near the Weger's ligament in the retrolental space, which is also known as space of Berger. And in the posterior aspect, it is very close to the optic disc. And the place where it is close to the optic disc, there is an area of Mortigani, while in the retrolental space, it is also referred to as Berger space. You have Weger's ligament in the retrolental space. The diagrammatic representation of the various ligaments and the spaces that are associated with the Clockett's canal, anteriorly as well as posteriorly. ಸ್ಲೈಡ್ ಮೂವ್ ಆಗ್ತಾ ಇಲ್ಲ.
ಕರ್ಸರ್ನ ಈ ಮೇಲೆ ಇಲ್ಲಿ ತನಕ ಮೂವ್ ಆಗಲ್ಲ. ಕರ್ಸರ್ನ ಇದ್ರ ಮೇಲ್ಗಡೆ.
ಓಕೆ. Okay, after knowing the detailed anatomy of the vitreous, now we will come to the diseases of the vitreous. The commonest disease is vitreous liquefaction due to senility. Next you have vitreous opacities. There can be vitreous detachment from its firm attachments, and there can be vitreous hemorrhage, and you have a few vitreoretinal diseases. These form the diseases of the vitreous. Most common, as I told you earlier, is the degenerative change in the vitreous. How do you identify? Normally patient comes with floaters, and on slit lamp examination, absence of normal fibrillar structure and visible pockets of liquefaction, and there is appearance of coarse aggregate material which moves freely in the vitreous. So the collapse is referred to as syneresis. It's associated with collapse and opacities in the vitreous, and the patient complains of black floaters in front of the eye. These are the features of vitreous liquefaction due to senility, which normally occurs after the age of 65. Vitreous liquefaction causes can be classified into various categories. It is due to degeneration, senile degeneration. In high myopia also there will be vitreous liquefaction, and in diseases like retinitis pigmentosa there can be vitreous liquefaction. Post-inflammatory, whenever there is posterior uveitis of severe form, there can be vitreous liquefaction. Trauma to the vitreous, it can be either blunt or perforating injury, that also can cause vitreous liquefaction. There are some therapies like diathermy, photocoagulation and cryocoagulation. In these cases, the temperature is either more than the normal body temperature that is produced on the tissue, or it will be lesser in cryocoagulation. In the extremes of these temperatures, there can be vitreous liquefaction. And sometimes radiation also can cause vitreous liquefaction. Next common disease is vitreous detachment, posterior vitreous detachment. The detachment of the vitreous base and the anterior vitreous is the other form of vitreous detachment. Coming to the posterior vitreous detachment, separation of the cortical vitreous from the retina anywhere posterior to the vitreous base is referred to as posterior vitreous detachment. Vitreous base, as you know, 3 to 4 millimeter wide area of attachment to the vitreous near the ora serrata. So you can see vitreous only up till here, and whatever is there behind is detached. This is referred to as posterior vitreous detachment. Posterior vitreous detachment with vitreous liquefaction is referred to as synchisis. Synchisis is movement, and collapse of the vitreous is referred to as syneresis. It is of common occurrence, as I told you earlier, after the age of 65 years, it is very common. Vitreous liquefaction is very common. Whenever it occurs, posterior vitreous detachment occurs in eyes with senile liquefaction. It develops a hole in the posterior hyaloid membrane. The synthetic fluid then collects between the posterior hyaloid membrane and the interlimiting membrane of the retina and leads to posterior vitreous detachment up to the base, along with collapse of the remaining vitreous gel. And this can be very common. Posterior vitreous detachment can also be very common among the aphakics and myopics. This is the diagrammatic representation of how the posterior vitreous detachment initially starts. This diagram shows posterior vitreous detachment in the superior part. Later on, it can get detached in the lower part also to form total posterior vitreous detachment. The clinical features of posterior vitreous detachment will be flashes of light and lights and floaters. Slit lamp examination shows collapsed vitreous behind the crystalline lens. There is an optically clear space between the detached posterior hyaloid face and the retina. V's ring or Fuchs ring is the name given to the pathognomonic sign as it gets detached from the optic disc. Near the place where it gets attached to the optic disc, there is a kind of a ring by name V's ring that can be visualized through the slit lamp biomicroscopy when there is posterior vitreous detachment. So presence of V's ring or Fuchs ring is pathognomonic sign of posterior vitreous detachment. What are the complications that are associated with vitreous detachment? As I told you earlier, while describing the anatomy, it helps in the mechanical stabilization of the globe. Once there is detachment of the vitreous, when the stabilization is taken off, retinal breaks can occur, vitreous hemorrhage can occur. Retinal hemorrhage and cystoid maculopathy is nothing but accumulation of fluid in a macular region. So vitreous base and anterior vitreous detachment can also occur following blunt trauma, and it may be associated with, apart from detachment, it may be associated with vitreous hemorrhage, retinal hemorrhage, anterior retinal dialysis, and dislocation of the crystalline lens. Now coming to the vitreous opacities, as you know very well, vitreous is a transparent structure. Any non-transparent structure present in the vitreous will form an opacity and cause symptoms of floaters. Sometimes when you look at a bright object, you can see small blue circles which keep moving. As you keep moving your eyeball, it keeps moving along with that. It's a normal physiological phenomena which we observe when we look at a bright background, and this is referred to as muscae volitantis. These are all physiological opacities which we normally see. It is present in normal individuals also. It only represents residues or the remnants of primitive hyaloid vasculature. It is perceived as fine dots and filaments which drift in and out of the field against the bright background, as I told you earlier. Other vitreous opacities, persistent hyperplastic primary vitreous, which is one of the differential diagnoses for leukocoria. Leukocoria means white pupil. So persistent hyperplastic primary vitreous is one of the differential diagnoses for leukocoria. And why PHPV is present? Failure of the primary vitreous structure to regress combined with the hypoplasia of the posterior portion of the vascular network leads to PHPV. You will have what is known as leukocoria seen after birth, associated with other it can be associated with other abnormalities such as congenital cataract, glaucoma, long and extended ciliary processes, microphthalmus, and vitreous hemorrhage. The differential diagnosis for leukocoria will be retinoblastoma. Sometimes you will be asked what are the differential diagnoses for leukocoria. Of course, here in context with vitreous, we are studying about PHPV, and you should also know other differential diagnoses of leukocoria like retinoblastoma, congenital cataract, and ROP. CT scan can help in the diagnosis of various types of leukocoria. The treatment for persistent hyperplastic primary vitreous will be pars plana lensectomy and excision of the membranes with anterior vitrectomy. The visual prognosis is very poor in case of persistent hyperplastic primary vitreous. Inflammatory vitreous opacities can be observed in severe iridocyclitis. Exudates are poured into the vitreous in cases of anterior uveitis, which is referred to as iridocyclitis, posterior uveitis, choroiditis, pars planitis, pan-uveitis, and endophthalmitis. These are the conditions wherein there can be inflammatory vitreous opacities in the vitreous. Vitreous aggregates and condensation with liquefaction can occur. Commonest cause of this is also commonest cause of vitreous opacities. Condensation of collagen fibrillar network can be again due to senility or due to high myopia or pathological myopia, post-traumatic or post-inflammatory in origin. A rare condition by name amyloid degeneration can also cause vitreous opacities. In this case, you see amorphous amyloid material being deposited in the vitreous. It is a part of the generalized amyloidosis that is seen in the body. So in the vitreous also there will be amyloid material being deposited. This is a diagrammatic representation of the amyloid degeneration and amyloid deposition. Asteroid hyalosis. You can see shining crystal kinds of things in the vitreous. When it is fixed, when it's not moving, it is referred to as asteroid hyalosis. They are small, white, rounded bodies suspended in the vitreous gel, formed due to the accumulation of calcium containing lipids. Normally they are unilateral asymptomatic, and usually seen in old patients with normal or healthy vitreous. You must remember that asteroid hyalosis are fixed opacities. They don't flow as the movement, even if there is vigorous movement of the eyeball, they don't change the position, they are fixed in the vitreous. Asteroid hyalosis. There is a genetic relationship between this condition, diabetes, and hypercholesterolemia. Genesis is unknown. Normally, the treatment is not required for asteroid hyalosis. This is the diagrammatic representation of the asteroid hyalosis, as you see with slit lamp biomicroscopy. This is another diagram which represents asteroid hyalosis. Next, in contrary, you have another condition by name synchisis scintillans, wherein the particles which you see, the shining particles which you see, they keep moving with vigorous movement of the eyeball. Even if there is small movement of the eyeball also, there can be shower of these opacities being seen. And vitreous is laden with small, white, angular and crystalline bodies which are formed of cholesterol, seen in damaged eyes that suffered trauma, vitreous hemorrhage or inflammatory disease in the past. Vitreous is liquid and crystals sink to the bottom and they are stirred up with every moment. They are stirred up with every moment. You can see like beautiful shower of golden rain on ophthalmoscopy. For that matter, even with slit lamp biomicroscopy, you can beautifully visualize the beautiful shower of golden rain. So you must remember the differences between asteroid hyalosis and synchisis scintillans. Asteroid hyalosis, whatever shining spots that are seen in the vitreous are fixed in position, while in synchisis scintillans, they keep moving like shower of golden rain. Symptomless, and I here also, as they don't cause any significant loss of vision, the treatment is not necessary. This is a picture of synchisis scintillans. Sometimes the red blood cells can also cause opacities in the vitreous. It is caused by small vitreous hemorrhages or left out of the massive vitreous hemorrhage when it gets resolved or gets absorbed. In such cases also you can see some red opacities in the vitreous. This is a picture which shows red opacities in the vitreous gel. Sometimes in cases of malignancy, in case of retinoblastoma and reticulum cell sarcoma, you can see tumor cells which are freely floating in the vitreous, and they can be the source of opacities in case of in the vitreous gel. Vitreous hemorrhage can also cause, vitreous hemorrhage is another condition. It usually occurs from the retinal vessels and it may be present as pre-retinal. You must know that pre-retinal hemorrhage is subhyaloid hemorrhage or an intraocular hemorrhage. Intraocular hemorrhage may involve anterior, middle, posterior or whole of the vitreous body. Many a times you will be asked, when do you see boat-shaped hemorrhages? Boat-shaped hemorrhages is nothing but subhyaloid hemorrhage, that is below the vitreous or behind the vitreous. It is also referred to as pre-retinal, in front of the retina. So whenever you are asked, when do you see boat-shaped hemorrhages, you are supposed to use these two terminologies. Pre-retinal hemorrhages, also known as subhyaloid hemorrhages, assume the shape of boat. Okay. The causes for vitreous hemorrhage: spontaneous vitreous hemorrhage from retinal breaks, especially those associated with posterior vitreous detachment. Trauma to the eye, it can be either blunt or perforating, as I told you. Inflammatory diseases, vascular disorders, hypertensive retinopathy or central retinal vein occlusion can also cause vitreous hemorrhage. Metabolic diseases like diabetic retinopathy, blood dyscreasis, these are the causes for vitreous hemorrhage. Bleeding disorders, then neoplasms, and sometimes it can be idiopathic also. What are the clinical features of vitreous hemorrhage? There is sudden development of floaters when there is a small hemorrhage. But if there is a massive vitreous hemorrhage, patient complains of painless sudden loss of vision. So this is one of the differential diagnoses for sudden painless loss of vision. What are the signs of vitreous hemorrhage? By distant direct ophthalmoscopy. As you know very well, in direct ophthalmoscopy, you have distant direct ophthalmoscopy and near direct ophthalmoscopy. While doing distant direct ophthalmoscopy, it reveals a black shadow against the red glow in small hemorrhage and no red glow at all if the hemorrhage is massive. You see no glow at all. The choroid is not seen at all by distant direct ophthalmoscopy. Direct and indirect ophthalmoscopy may show presence of blood in the vitreous cavity. So ultrasound with B scan is particularly helpful while diagnosing the vitreous hemorrhage to know whether only vitreous hemorrhage is there or there is associated tractional retinal detachment. Well, the retina is flat. For that purpose, you have to do what is known as B scan of the eye. What happens to the vitreous hemorrhage? Many a times it gets resolved on its own. Complete absorption may occur without organization, and the vitreous can become crystal clear within 4 to 8 weeks. But sometimes the organization of hemorrhage with formation of yellowish white debris occurs in persistent or recurrent bleeding. Some complications like vitreous liquefaction, degeneration, and Coxyl glaucoma, especially in aphakia, may occur due to vitreous hemorrhage. Retinitis proliferans may occur, which may be complicated by tractional retinal detachment. Retinitis proliferans is nothing but organization of the vitreous, and then it is converted into fibrils that can cause traction over the retina, and then it can pull the retina, causing tractional retinal detachment. Treatment for vitreous hemorrhage: conservative treatment consists of bed rest, elevation of patient's head, and bilateral eye patches to allow the blood to settle down. Next comes the treatment of cause. Once the blood settles down, indirect ophthalmoscopy should be done to locate and further manage the causative lesion such as retinal break, phlebitis, etc. The third line of treatment is surgical line of treatment, vitrectomy by pars plana route, which I'll be telling you in detail in my last few slides, should be considered to clear the vitreous if the hemorrhage is not absorbed within 3 months. Normally, any hemorrhage gets absorbed on its own within 3 months. So, we need not immediately operate the case, wait and watch. If it doesn't get absorbed within 3 months, then only you are justified in doing vitrectomy by pars plana route. Next, whenever you talk about vitrectomy, you must know various types of vitrectomy. The first type of vitrectomy which you are supposed to know will be open sky vitrectomy. Open sky vitrectomy, because it's not a closed chamber, you have opened the chamber at the sclerocorneal junction, and hence the name open sky vitrectomy. Indications for open sky vitrectomy: you may be asked what are the various types of vitrectomy. In such cases, this particular slide will help you in naming the first kind of vitrectomy, that is open sky vitrectomy. Indications for open sky vitrectomy: vitreous loss which is seen during cataract extraction. When you are doing aphakic keratoplasty, there also you do open sky vitrectomy. Anterior chamber reconstruction after perforating trauma with vitreous loss, and removal of subluxated and anteriorly dislocated lens. In such case also, open sky vitrectomy is indicated. So what are the various types of vitrectomy? Anterior vitrectomy, it refers to removal of the anterior part of the vitreous. Next one is core vitrectomy, which refers to removal of the central bulk of the vitreous. And removal of the central bulk of the vitreous is usually indicated in case of endophthalmitis. Subtotal or total vitrectomy, the whole vitreous cavity is pathological. You are supposed to remove the whole of the vitreous, and that is referred to as subtotal or total vitrectomy. It is almost whole of the vitreous being removed. Sometimes you will be asked what are the various methods of doing posterior vitrectomy. So you must know very well that posterior vitrectomy is done in a very safe zone, and the name of this safe zone is known as pars plana. And you may be asked, well, what is the area in which the pars plana is present? So in relation to pars plana, you are supposed to remember pars plicatum also, but here I will describe only about pars plana because this is related to posterior vitrectomy. Pars plana is present in a normal eyeball stretches from 4 mm to 6 mm from the limbus. So the pars plana area, which is used for posterior vitrectomy, stretches from 4 mm to 6 mm from the limbus, and that being a relatively avascular zone, whatever instruments you can pass any kind of instruments in this particular place and do posterior vitrectomy. The old methods of vitrectomy, we used to have an instrument by name whisk apparatus. Many a times an examiner may ask you what is whisk apparatus, just to complete your YOOC or to conclude your YOOC. So you must know that whisk apparatus is nothing but vitreous infusion, suction, cutting and illumination. All the equipments used to be in one particular probe, and this is referred to as whisk apparatus, but it's an old method. Now it is not practiced. The new method is 3-port vitrectomy. Whatever equipments I told you earlier, they are divided into 3 parts. See, infusion is by saline infusion. Then suction and cutting is done by the vitrectomy machine. And endoilluminator is illuminating the vitreous. And you cannot see the vitreous with the naked eye. You have to have an operating microscope, and you have to have special contact lenses to visualize the posterior segment or the vitreous whenever you are doing vitrectomy. It's a sophisticated, highly advanced micro surgery for which you need all these equipments: operating microscope, contact lens. Then you have to have 3 ports. In one port there is infusion of saline, balanced salt solution, or you can also use Ringer's lactate solution to infuse. And you have to have a contact lens, you have to have a vitrectomy apparatus, you have to have source of illumination. With the fiber optic, you convert that into an illumination of 18 gauge, and then there must be a port through which you can illuminate the vitreous so as to visualize through the microscope as to what you are doing. Sometimes if you don't want contact lens, if you don't want to touch the cornea, then one more instrument by name BIOM, binocular indirect ophthalmo microscope. So BIOM can be used. That doesn't touch the cornea, but still you can see the details of the vitreous by this particular equipment, BIOM. So here now we are doing 3-port vitrectomy. We are not using a single instrument like whisk apparatus, which we used to use earlier. The diagrammatic representation, and for irrigation, aspiration and cutting, illumination, endoillumination, you have 3 ports. One is for irrigation, wherein previously we used to use 18 gauge irrigation cannula. Now we have converted it to 23 gauge cannula, and most of the instruments are 23 gauge. There is an endoilluminator, and there will be vitrectomy cutter, which not only cuts the vitreous but it also aspirates. So vitrectomy cutter equipment will be having both a cutting facility plus an aspiration. This is the recent equipment. If you are asked what is the recent equipment that is used for posterior vitrectomy, you have to mention this equipment, which is nothing but endoscopic Vitrectomy. Endoscopic vitrectomy, the equipment looks like this, the console looks like this, as you see in the left part of the picture. The right part of the picture is what you see in the posterior segment. But you cannot see through and through like how you see pole to pole in operating microscope. You will be seeing this picture in the attached CCTV, and in the television you are supposed to visualize the structures, and you are supposed to do the operation by looking at the television monitor. Thank you. I think that concludes all the things that you are supposed to know about Vitreous.